Greetings, this is Dan Davis coming to you on April 28th, 2020 for your weekly COVID-19 update. Today I'm going to be talking about treatments and vaccines, including some new and potentially very exciting news. For my title slide, I included some images for you to look at, including the coronavirus on the left and a bottle brush plant on the right. You can see that they share some interesting features that seem to be conserved throughout nature. So where are we at? Well, here we see today's data coming from the Los Angeles Times regarding new cases on the left and deaths on the right. You can see, as predicted, there was a little bit of an uptick in the middle to end of April here, which reflected in part spread through Los Angeles County, as well as an increase in testing. Overall, deaths seem to have peaked in the middle of April and are now starting to fall, which is a good sign for all of us. If we look at California county by county, you can see Los Angeles County there at the top, and that secondary spike, which probably reflects both an increase in spread, but also an increase in testing and an increase in diagnosis that comes with testing. My favorite metric are the number of influenza-like illnesses in the emergency departments. And you can see that toward the middle to end of March, there's a sharp spike that was not explainable by the annual flu season, but instead represented cases of coronavirus that has since fallen off. So hopefully this reflects that we've weathered the initial storm of coronavirus. So what happens next? Well, I think the talk in the news has been about easing restrictions and this move towards, quote, the new normal, which nobody appears to be exactly sure what that might look like. One thing we do know is that we need to have rapid and aggressive testing so that as little fires spring up, we can rapidly identify and test not only the cases that appear to be symptomatic, but also their contacts and isolate individuals that we think have coronavirus or may have been exposed to coronavirus. Most seem to think that if this coronavirus behaves like other coronaviruses, we'll see a summertime lull, but that we really need to prepare ourselves operationally and mentally for the next, quote, flu season, which this year may include coronavirus as well as the usual influenza. That brings up our potential responses when we do see an increase in cases. Probably the best metaphor is the idea that we had to slam on the brakes this time through, in part because we did not have rapid testing available. But going forward, we may be able to, quote, pump the brakes. That is, slow things down when we see an increase in cases rather than having to slam the brakes on the entire country. And that brings up an interesting concept, the idea that the pumping of the brakes may occur on a local level, whether that would include an entire state, a county, or in the case of Avalon, a city. But there are some questions that we need to consider. The most important being, how much disease are we willing to tolerate? We seem to be balancing the desire to minimize illness, particularly deaths, against the consequences of shutting down an entire economy. It's almost certain that we will see a continued restriction on larger gatherings, and the likelihood is that we'll be wearing masks routinely when we go into crowded public places, at least for the foreseeable future. I think what most politicians are trying to avoid is the constant opening and closing of businesses, particularly those that have a large impact on the economy. And no one wants to return to the shelter in place that we've experienced over the past month. And so the hope is that by pumping the brakes and addressing small breakouts of coronavirus on a local level, we can avoid the country or statewide shutdown that ends up effectively slowing the virus, but potentially slowing the economy as well. So one of the important considerations is whether we should be monitoring new cases or the availability of ICU beds. The concept of avoiding new cases would be most relevant if we were trying to squelch the virus completely and avoid any spread throughout the community. This would go directly against the idea that we will not achieve herd immunity until 60 to 70% of us have been exposed to the virus. But thus far, the rates of positive antibodies have been relatively low, particularly in California. The alternative is to let the virus roll through the community, try and limit exposure to vulnerable individuals, such as those who are over the age of 65 or have other illnesses, and monitor the number of ICU beds or ventilators available to make sure that the healthcare system isn't overwhelmed, but accepting that many people are going to contract the disease, but that is preferable to crippling the economy. These are two very different approaches that force us to face some very difficult and almost unanswerable ethical questions. Now, what about therapeutics? One of the middle ground positions is to attempt to keep the virus at bay and minimize infections while we wait for either a vaccine or some sort of therapy. Potential therapies include antiviral agents, that is, medications that attack the virus directly or limit its ability to infect or reproduce, versus agents that focus on the immunological response. Part of the challenge of coronavirus is predicting which individuals are going to develop the severe form of the illness, which includes ARDS, or the need for a mechanical ventilator in an ICU, and potential death. Certain medications accept that some illness will occur but try to minimize the chance of these more serious complications. We'll talk a little bit more about antiviral agents and immunologic agents on the next slides. One of the interesting things that we've learned about the coronavirus, and specifically COVID-19, which is the disease that it causes, is that patients seem to have their clotting system activated in a way that leads to widespread thrombosis. That is, the formation of clots in places like the deep veins, which can then fly off and plug up the lungs, or even in blood vessels that supply the heart and the brain, leading to heart attacks and strokes. More aggressive ICU care has included the use of anticoagulation medication, such as blood thinners and even thrombolytics or clot busters. Ultimately, the hope is that there will be a vaccine that can be administered initially to the most susceptible individuals, but eventually to everyone, that will prevent the disease altogether. So what about hydroxychloroquine, with or without azithromycin? This combination has received much attention in the press. However, a recent trial, which randomized patients to receive hydroxychloroquine and azithromycin, suggested that mortality doubled with its use. In response, the recommendations have been not to use hydroxychloroquine, which is disappointing. A number of antiviral medications are being discussed, including the use of medication normally reserved for HIV disease. There are some similarities between coronavirus and HIV, and in laboratory experiments, the HIV medications appear to be effective at reducing the reproduction of the virus. For those who are interested, coronavirus, like other viruses, carries a set of blueprints, but can't actually reproduce without the help of other organisms. Essentially, it brings its blueprints into another cell, in this case a human cell, and uses the machinery that would normally produce human proteins to make new copies of the virus. It requires certain enzymes in order to complete this process, and many of the HIV medications deactivate these enzymes, making it impossible for the virus to reproduce. Other strategies include the use of medication designed for other types of virus, and one example includes favipiravir, which was recently approved in China for use against coronavirus. This medication previously had been developed to treat influenza. Unfortunately, other influenza therapies do not seem to work against coronavirus. Besides hydroxychloroquine, the other drug that's received quite a bit of press is remdesivir, which was initially developed for use against Ebola, but now appears to have found a niche in treating coronavirus. Many patients hospitalized in the United States have already received remdesivir, and we're waiting for studies that demonstrate whether this is an appropriate treatment or not. The problem with remdesivir is that it's only available as an intravenous medication, which means that at a minimum a patient would be required to be in the hospital. In addition, some strains of coronavirus appear to be resistant to remdesivir, so we're not sure how long remdesivir would be effective, even if it does demonstrate promise in these early studies. A medication about which I'm particularly excited doesn't even have a real name yet, but has already entered human trials. The reason that I'm particularly excited about this medication is that it's A, available as a pill, and B, it seems to work not only against the current strains of coronavirus, but even against the remdesivir-resistant strains. If this medication proves itself safe and can rapidly reduce the amount of virus in an infected individual, we may see this become available even later this year or early next year. Many immunologic treatments have been tried, including hydroxychloroquine. Because the more severe form of COVID-19 involves an overactivation of the immune system, targeting specific parts of the immune system seems to be a popular approach, including a particular immune signaling molecule called interleukin-6. Because there are several medications already available that target this part of the immune system, it was relatively straightforward to start to study these in patients with the severe form of COVID-19 from coronavirus. Now, we're currently operating under a central principle that patients who recover from coronavirus or COVID-19 develop antibodies against the virus. That is, their immune system learns to recognize the specific parts of the virus. The initial strategies have focused on taking antibodies from individuals who have recovered from COVID-19 and injecting them into patients currently fighting the disease. But going forward, there may be specific antibodies that we can isolate and mass produce that recognize and attach to a specific feature of the coronavirus and prevent it from attaching and entering a human cell, limiting its reproduction. Here are some data that were just published from the oral medication that I mentioned on the previous slide. And you can see that there's a very rapid decrease in the amount of virus as the concentration of the medication increases. The good news is that almost complete suppression of the virus can occur at levels that are achievable with an oral medication. That is, a patient could take a pill and get high enough levels within their body to completely suppress the virus. And that applies not just to our current coronavirus, but also to the previous SARS infection, to MERS infections, and even to mutated forms of the current coronavirus that might make it resistant to remdesivir. So what about a vaccine? Well, it's important to understand how a vaccine is developed. First, a vaccine has to be made, and in the past, it just involved killing or wounding the virus and injecting it into humans so that their immune system would learn to recognize the virus without the virus potentially making them sick. The problem with that approach is that a large amount of the virus is required to be able to make millions and millions of immunizations, and we don't do a particularly good job of growing virus in cultures. With any new virus, we have to see if it triggers the production of antibodies, and we have to see if it's safe to administer to humans. That's really important because two things can happen. One is that the immune system can learn to recognize the virus, but in the process can learn to recognize and then attack other parts of a normal human body at the same time. We call this process autoimmunity. In addition, it's possible that if the immune system learns to recognize a virus, that when it sees it again, it may trigger an over-response, which we call enhancement. a super response that can lead to even more symptoms than the patient otherwise might have experienced. Once we know that a vaccine is safe, it then has to be tested in a natural environment to see if it actually prevents the disease. And that requires thousands and thousands of patients, particularly if only a small handful actually contract coronavirus with current containment measures. Scientists don't consider it ethical to deliberately expose people to a disease that could be life-threatening just to see if they catch it. All along the way, we need to figure out not only the dose, and we need to understand how long the immunity lasts, whether this is something we have to update every year, every other year, every 5 years, or if a single dose confers lifelong protection. Finally, we need to figure out how to mass produce the vaccine, because again, it's not necessarily easy to grow virus in culture, and other strategies are being explored to better produce vaccines without the challenges of growing viruses in culture. With all the difficulties in producing vaccines, it turns out that not a lot of pharmaceutical companies are that interested because they can't make a lot of money. As evidence of this, you've seen Bill Gates trying to fund the development of these vaccines, knowing that drug companies may or may not be interested in producing something that ultimately doesn't bring a lot of profit. And depending on how much and how frequently it needs to be given, the requirements may be huge to produce tens of millions and even billions of doses, or if everyone is immune from the very first injection, it may limit the long-term profitability of developing human vaccine. In addition, there are some unique features of coronavirus that make it more challenging. We haven't yet figured out how to easily grow it in culture, unlike influenza, which we grow in eggs. And because it's an RNA virus, it tends to mutate quite a bit. So it's possible that we would have to develop strategies like for influenza, where every year we vaccinate against a different strain. All of that being said, there was just some news released today that suggests we may have a vaccine much faster than we anticipated. A group out of Oxford had been trying to develop vaccines using viruses that are much easier to grow in culture to produce the vaccine against other pathogens, in this case, coronavirus. Because they had already worked through many of the initial steps and had demonstrated that it was safe to give to humans, they've been able to leap forward and actually not only create a vaccine against coronavirus and demonstrate that that vaccine can prevent monkeys from getting coronavirus, but also demonstrate a viable strategy to mass produce the vaccine if it ends up being both safe and effective. Large-scale human trials may start immediately, and we may have an answer and even a viable commercial vaccine later this year. Even if the vaccine were initially only available to protect the vulnerable, its availability could at least help prevent the need to, quote, pump the brakes and intermittently close down our society, because the mortality for the disease would be very low if the most vulnerable individuals could be protected. So what does all this mean? Well, I think we've weathered the initial storm, and we're now seeing a decline in the number of new cases, and I believe that most hospitals feel that they won't be overwhelmed with severely ill cases. As our social isolation is slowly released, we must be nimble with testing and isolating affected and exposed individuals. Ideally, we would see the disease disappear completely, but the ideal in the short term, before the flu season this fall and winter, would be that we can identify some drugs that will lessen the severity of illness and maybe even see a home run either with the oral agent or the emergence of a vaccine in the short term. And in the long term, before the 2021 to 22 flu season, we will have a viable vaccine that will reduce spread through the community and certainly protect those who are most vulnerable. So as you can see, there's some hope on the horizon. Hopefully this will help you navigate the constant barrage of information in the press and help you identify the important next steps in our approach to coronavirus, as well as the potential therapies and vaccines available. Thank you very much for listening.